So welcome to this talk about history taking that was being given to the Warwick Clinical Skills Society here at the University of Warwick. Uh, we've chosen to record both of our talks that were given side by side, so the people who didn't get to see one talk can hear the other talk as well. And it's going to focus on the four frames. The four frames model is the model that Warwick Medical School uses to break down clinical history taking, which is a really, really important skill that's going to serve us well throughout our clinical careers. Every medical school will have its own way of breaking down history taking, and we just use the four frames model here at Warwick. So what are the four frames? Well, we've got history of presenting complaint, the past medical history, social history, and ideas, concerns, and expectations. And we spend most of our time talking about the history of the presenting complaint. But before we do that, we always have to introduce ourselves to the patient. We use the acronym WIPE to remember how we introduce ourselves. So we're going to wash our hands, we're going to say who we are, what our role is, identify the patient, and then get consent. But you only get consent if you've explained what you're going to do. So go and see the patient, I wash my hands, put on PPE, and say, "Hi, my name is Jonathan Looms Rodeliak. I'm a final year medical student. Can I take your name and date of birth, please?" Once they've given you that, you say something along the lines of, "I've been asked by the doctor to come and talk to you just to see why you're here and how we can help you. Is that okay?" They'll consent, and then we can head off into our history of the presenting complaint. Now, almost all the time when it comes to hospital, when it comes to GP, and when it comes to your OSCEs, you'll always be given the presenting complaint before you go and see the patient. So it'll give you some time to think about what sort of questions you might want to ask. But no matter what the history is, you always want to start off A, with an open question, and B, with the same question. Just make sure you pick an opening question that works for you, that you can say quite fluently to begin your consultation, and make sure it's an open one. So it could be, "How can we help you today?" or "What appears to be the problem?" Learn it and just get used to saying it. Then once you've got the opening question and have heard a bit from the patient, start asking some more open questions. They're going to help you, give you some clarity about what's going on, and perhaps explain a few things that the patient has said to you that doesn't quite make sense. Also start adding in some closed questions at this point to help with the clarifications. Then we're going to move into a system-specific set of questions and systems review before finishing with our red flags. So, if you were here now, I'd be asking you, what open questions would you ask about a patient with a cough? So, we want to try and understand a bit more about the particular cough, and I hope you come up with certain answers like this. When did it start? How would you describe the cough? So, maybe they'll say it's a tickly cough or a dry cough, or maybe they're saying they're bringing stuff up with it. And if they say they're bringing stuff up, you might want to say, "Oh, tell me more about that." Or what are you bringing up? And they could talk about finding blood in there or different colours of mucus. When is a cough worse? What makes the cough better or worse? Point about this one is, don't ask double questions. Ask one question, what makes the cough better, and then ask the second question, what makes the cough worse? You can ask, what time of day do you get the cough? Or what are you doing when you start to cough? Or where are you when you cough? And you can also ask, what have you tried? You'll be surprised at the number of patients who come in with some sort of joint pain and they've not even tried paracetamol. So, really, really important question to try and ask and gauge their expectations of what you might have for them. And also, all these questions, if you notice, don't require any knowledge whatsoever of what could be causing a cough. They're very open, generic questions. You don't have to memorise them, but just get into the sense of sort of these what, when, where, how questions can be really powerful in exploring more of a patient's presenting complaint. After you've asked a few of these, you can then also ask any other symptoms. No, it's not really an open question, I admit, but it can help bring up more questions or more issues that the patient has that they haven't thought are linked to say, their cough. And they could, for instance, say, oh, I've now got some really bad pain in my chest. And of course, if they ever say pain, we go straight into our pain history. So the various mnemonics here, SQITAS and SOCRATES, seem to be the two most popular. And what I'd say to you is pick one of them and learn to recite it without thinking about it. When I'm talking to patients now and being interviewed or being assessed by my consultants, I'm frequently told I'm not asking enough open questions. I'm not asking a comprehensive pain history. So if you ask some open questions and get this pain history down properly, you're well on your way to passing finals. So after we've explored the main part of the presenting complaint, we'll have some sort of idea about what sort of systems could be involved in the patient's problems. So I'm thinking, perhaps if they've got a cough, maybe it's going to be a respiratory problem based on some of the questions I've asked. So now I'm going to click into the respiratory system. So there are a whole lot of sets of questions that Warwick Medical School give us that help us understand and explore different systems. So we're going to ask some of these questions, and then after we've done this systems-based questions, we might also want to think about any other systems that could be involved as well. So for instance, with a cough, it might just be caused by respiratory problems. Say it could be caused by anxiety or become a habitual cough, or it could be maybe patients got gored. So you want to explore that in case that's the cause of their cough. So just thinking what other systems could also be affecting it. But the bulk of the systems review is really about picking a system that you think is most relevant to the patient and then exploring some of these questions. So at Warwick, we're currently in block 1, which is a block about gastrointestinal problems and health and metabolism. So we're going to look at the GI system and the GI systems review, which is really, really helpful because it goes from mouth to anus and you can think about the different aspects of the digestive tract when trying to work out what's going on with your patient. And what I'd say is make sure you have an idea of what the questions are asking and why you're asking those questions. So asking about any ulcers in the mouth, if they have mouth ulcers, it could be a sign of Crohn's disease. If they have difficulty swallowing, there could be something in some sort of obstruction, maybe a cancer of the esophagus. Also ask about any indigestion or heartburn. Again, if they say yes to any of these questions, you want to explore those with more open questions. So any indigestion or heartburn, what sort of time of day do you get it? What sort of foods are you eating when you get these problems? Say heartburn's a pain, you're going back into your SQUITAS and pain history if you wanted to. We come to the stomach to ask about nausea or vomiting. Say if they have been sick, you can say, can you tell me more about your vomit? Can you describe your vomit to me? Green vomit could be a sign of bile, so they could have a small bowel obstruction. If it's coffee ground vomit, when it's got lots of sort of brown spots in it, it could be a sign of a bleed. Let me move down to the bowels, large and small bowel. You could say, have you noticed any change in your bowel motions? And then if they say no, you can just clarify. So no constipation or straining, no diarrhea, any change in colour. So colour can be quite important here as well. So if you have a black tarry stool, it's probably a sign of an upper GI bleed, and we call this melena. If it's a very, very pale stool, particularly if they're yellow and they've got dark urine, that could be a sign of obstructive jaundice. And then once we get into the rectum and anus, we can ask about tenesmus. Now, a patient is not going to understand the technical jargon of tenesmus. So you want to ask it in a different way. So, do you feel you need to go to the toilet just after you've been? If they say yes to that, it could be a sign, again, of inflammatory bowel disease like Crohn's and UC. So we've explored our systems, and now we're going to move on to our red flag, which is the last part of the history of the presenting complaint. So we ask, change in bowel habits, any nausea or vomiting, any weight loss or appetite change, any lumps or bumps, any bleeding. And Also, then, if they say yes to any of these questions, just explore a bit more about those. Where is it? When is it? Etc. So that completes our history of the presenting complaint. We then move on to the past medical history. I'm not going to say too much about this, other than you're just trying to understand what the patient's current medical problems are, their past surgical history, past major medical history, and then the medications and allergies. Now, you're going to find when you talk to a real patient that you'll say, do you have any medical problems? And they're going to say no. And you say, are you on any medication? They're going to give you a list of 7 medications that show that they have COPD, an enlarged prostate, diabetes, and high blood pressure. Equally, just because the patient doesn't have a medical condition doesn't mean they're not on medication. So, for instance, the oral contraceptive pill or statins. So, both questions are important. Don't just assume if there's no answer to one, to the first question, they're not going to have answers to the second question. I'll also say, though, in your OSCEs in an exam situation, particularly in first year, if you say to the AXA, do you have any medical problems? They will tell you what they've got. They'll say, and if you've got any regular medication, they will answer honestly to that question. But in the real lives, and perhaps as we get later into the course, you might have to dig those questions out yourself. I'd also say that there are various mnemonics out there for listing medical conditions you might want to see if the patient's got, which is really useful for sort of capturing some really important ones that may affect your management. So a patient, for instance, with heart disease or heart failure, you may want to sort of treat them a little bit differently when it comes to IV fluids. But the really, really important thing here is to ask about allergies. And I like to ask this in 3 ways. Do you have any allergies? Have you ever had any bad reactions to medication in the past? And particularly penicillin. And if they answer yes to any of these questions, you want to work out what happens when they have this allergic reaction and document that in the notes. So after our past medical history, we move on to social history. And this isn't just some pink and fluffy thing that we ask because it's part of our 4 frames model. The social history is really important, particularly in respiratory and MSK exams, also histories, but also really important to understand the factors that are going to influence how well the patient's going to sort of comply with treatment, and other problems that they may face that could be contributing to their presenting complaint. There are lots of different ways to skin this particular cat. One mnemonic you might want to try is how I lost my family. So the how is this affecting you? So a patient comes to see their GP with some sort of chronic problem. How is this affecting you at home? How's this affecting you at work? Some very powerful question to get the patient to open up about the real impact it's having on their life. And also getting you a sense of what you're going to have to do to try and help the patient get back to a semblance of self and better quality of life as well. Lost then stands for lifestyle, occupation, smoking and other vices, and travel. And lifestyle, really important, so living situation, who they live with. Do you care for anyone? So a patient may be very reluctant to come into hospital or stay around for some investigations if they're worrying about someone they need to get back to because who depends on them. You can ask about diet, particularly in GI histories and cardiovascular histories. Occupation is particularly self-explanatory, but again, some occupations may increase the risk of certain health problems, particularly sort of cancers and things like that. So again, if the patient says they're retired, just say, so what did you used to do for a living? Then we come to our vices. I like to ask about alcohol first because it's the most culturally acceptable vice. So do you drink at all? Do you smoke at all? Any recreational drug use? And don't be embarrassed about asking these questions. Just do it in a non-judgmental way. And if they are offended, you can just apologise and say, I'm sorry, we just ask these questions of all our patients. One way I sometimes ask about recreational drugs is actually say, have you ever used recreational drugs? So I'm not making any judgment about the patient at this particular point in time, but I'm also picking up on any sort of past drug use that could contribute to some more insidious problems. So, for instance, if they've previously been an IV drug user, maybe things like liver cirrhosis or other problems could have a link to some blood-borne virus like HIV or hepatitis. But with smoking and alcohol in particular, if they say they just smoke or drink, clarify how much they're smoking or drinking. Because it could be a question in your OSCE, okay, can you tell me this patient's pack history, or calculate their weekly alcohol units, please. And then travel, again, pretty self-explanatory. And then finally ask about their family history. Again, the family history is really important because it could tell you about things that either on their mind or could be causing their problems as well. So you could say to the patient, how are your parents? And they'll say, or how are your parents' health? And they'll say, oh, not too good, I'm afraid. Unfortunately, my father died of bowel cancer a few months ago. Then don't just go, cool, don't just tick off that box. Just say, empathise with your patient and say, oh, I'm really sorry to hear that. How are you feeling now? And then you could also perhaps inquire, if it's relevant, is this something or worry that you could have based on your symptoms? Capturing their concerns early on as well. But also remember, family history isn't just about the parents, it's about grandparents, it's also about siblings as well. And picking up sort of funnier conditions that run in the family. So you could say, yeah, are there any funny or rare conditions that run in the family? How's your parents' health? And as you get more familiar with the different types of conditions and the potential differential diagnoses, you could ask some more pertinent questions, perhaps something along the lines of, how is anyone in the family who's got a thyroid problem or diabetes? Because they could help you with your differentials if that's where you're sort of edging towards. So once we've finished with our social history, move on to ICE, which is our ideas, concerns, and expectations. And the challenge here is always asking about ideas, concerns, and expectations without using the words ideas, concerns, and expectations. So you could say, what do you think is going on? Is there anything particularly worrying you about your symptoms? And you could also, for expectations, say, is there anything specific you were hoping we could do for you? And that's an important question as well, because it helps you get your balance right and anticipate what you might have to say to them if you're thinking this requires a different level of management. Also consider asking, or also ask, is there anything I've not asked that you think is important, and do you have any questions for me? These 5 questions are so important that Vinod at Warwick recommends that if you're running out of time, jump to these 5 questions and make sure you cover them. You can always jump back to them at the if you still have time afterwards, but these questions are so important for sort of making sure the patient is being listened to and we're looking at the right problems for the patient. So that is our 4 frames. So the history of the presenting complaint, we look at open questions, then clarify with open and closed questions and pain histories if appropriate. We do a systems review and highlight red flags. We have our past medical history. We look at medical and surgical problems, medications, and definitely not forgetting allergies. How I lost my family in the social history, and then ideas, concerns, and expectations in ICE. And there are our 4 frames. So just going to close now with some final tips. In OSCE settings, when you're talking to actors, when you're talking to your peers, pretending to take histories, pretend you're talking to a real patient. Just helps you get into that mindset of being able to empathise and being able to sort of pick up on what people are saying. A history with an actor or with a colleague is different to a history with a real patient. But even some real patients can be quite taciturn in their responses, and you're going to have to learn how to dig the answers out of them. Also, it's really, really important to listen. Dan, the person who's presenting the other presentation next to this one did some polling in Twitter. He asked the Twitter sphere advice for history taking, and the most common bit of advice was to listen to the patient. You're going to find out so much if you actually listen. Also, remember, you're a human and not a robot. So by that I mean, again, just don't do that tick box exercise. We're giving you lots of tools here about how to approach a patient's history and what sort of questions to ask. But don't just do a tick box exercise. Respond to the patient if they feel like there could be some sort of emotional aspect to this. And make sure you're sort of responding to any other sort of signs as you're going along. And then summarize. So if you ever get lost in a history and you've lost your train of thought, summarize what the patient's told you so far. It shows to the patient that you're listening, and it gives you a few minutes just to get your head together and work out exactly what it is you need to do next. And are there any other questions you can ask? So I hope you found that helpful. If you were here now, I'd ask you if there are any questions. And by virtue of the fact that you are watching this video, you probably found the MedGuide page below. So please have a go at these questions. Some of them are linked directly to these talks, and some of them are just some tangential questions that will hopefully help you explore your current gaps in knowledge about history taking and some basics about medical management. Thank you very much.